in terms of what subsequent line therapies can be used in a patient who progresses on an ALK inhibitor, it's now relatively easy in the United States to pick one of the 3 drugs that are in the NCCN guidelines for first line. I already told you alectinib and brigatinib have an edge for better CNS penetration, even though ceritinib does penetrate the CNS as well. Crizotinib, one would not use in the United States because it has really a big delta in terms of its inferiority to the other ALK inhibitors. So that's not really an optimal choice. After failure on one of these newer generation ALK inhibitors, you would do a biopsy, tend to use the next one. For example, if you used alectinib, there was G1202R, you know that you can pick brigatinib or lorlatinib. In terms of toxicity profile, brigatinib would win over lorlatinib. So that would be the optimal choice. When that fails, maybe you try lorlatinib, and ultimately resistance develops to all of them, and then you go back to a platinum-based doublet therapy, which still works in these patients. So when we think of the choice of brigatinib after alectinib in this patient and try to look for evidence, there is limited evidence. We know it's a rare disease, and the patients get parceled out into smaller and smaller subsets, and you can't really do large randomized trials at every line of therapy. So when you look at the abstract from last year's American Society of Clinical Oncology, Dr. Stinchcomb had an abstract of patients who had failed on second-line or second-generation ALK inhibitors and the use of brigatinib, and they were actually in a group of 19 evaluable patients, 8 responders. And obviously you don't expect a very high response rate, but I think these are small numbers. 8 out of 19 is a respectable proportion of patients. At least it gives biological evidence of activity in the clinical setting. So I think that bears out the choice that was made to give the patient brigatinib. There was another publication by Dr. Karen Rackham, which really is a cross-trial comparison. And we always say we don't do cross-trial comparisons, but honestly, in clinic, we do it all day long, every day, when we have a patient in front of us. And she concluded in her analysis in this trial, where they use patient-level data from ALTA, but they also used trial-level data from publications for the other ALK inhibitors. She concluded that on the basis of efficacy versus toxicity, brigatinib is superior. That was the author's conclusion.